Okay, everyone, welcome to Hypertension 2018. My name is Nina Vasavada. I'm one of the nephrology faculty here. So I'm boarded in nephrology and internal medicine. There's also a certification I have called a Certified Hypertension Specialist, which is a board certification you can get through what was formerly known as the American Society of Hypertension, which has joined the American Heart Association. So we have several objectives for our talk today. The first one is we're going to discuss the approach to the ambulatory patient with elevated blood pressure. This is in contrast to hypertension, hypertensive emergencies, and I believe you all have a separate didactic for that. We're going to talk about the difference between primary versus secondary hypertension, and we're going to go over some special population management of hypertension. In addition to all of this, hypertension is covered on the internal medicine boards, takes up about 5% of the questions. It's actually a huge amount. So that's distributed between nephrology, cardiology, and endocrinology. So I'll try to highlight throughout the lecture points that I think are important for you to know from an examination standpoint. Does anyone recognize this historical figure? That is FDR. So Franklin Roosevelt was the 32nd president of the United States. At the time of his presidency, he would have had access to the best medical care that was available during that era. And yet, the clinical course of his health really reflects where we were in the 1930s and 1940s with hypertension management. So when FDR assumed the presidency in 1933 to 1937, he was noted to have some health problems, including hypertension. So we have documented blood pressures in 1937 of 162 over 88, and in 1940 of 180 over 88. So these remained largely untreated. There were no thiazide diuretics, there were no beta blockers. At that time, some of the medications that were available included thiocyanates, which, as you know, can be implicated in cyanide toxicity and decreased kidney function. But even that was not applied to all patients. Much of what the care of a hypertension patient included rest, massages, limiting work hours. And so as you can see, in 1941, his blood pressure was 188 over 105. At that time, he was prescribed phenobarbital. In 1944, his pressure was 230 over 140. And during that episode, he was noted to have heart failure on chest x-ray as shown with cardiomegaly, pulmonary edema, and proteinuria on urinalysis. So in spite of all of that, there was no antihypertensive medication treatment given to him. And then in 1945, on April 12th, he had a headache. They checked his blood pressure. It was 300 over 190. And that day, he had a sudden death, which was attributed to a cerebrovascular accident. So during that era, the common thinking that was published in major cardiology textbooks was that if the blood pressure was less than 200 over 100, it didn't merit hypotensive treatment with medications. It would take another 22 years after FDR died for the first landmark clinical trial to be published, which would show an improvement in morbidity and mortality from treating blood pressure. So this was a study done by the VA Cooperative Study Group, published in JAMA in 1967. They looked at patients who had a diastolic blood pressure between 115 and 129. They randomized them to a placebo group and to a group that received hydrochlorothiazide, reserpine, and hydralazine. So at the end of 24 months, there was a difference in the diastolic blood pressures of the treatment groups, 91 versus 119, and they were able to document an improvement in the rate of major cardiovascular events such as stroke, MI, and death between the actively treated patients where there were 2 events and the placebo-treated patients where there were 27 events. So this really was the first landmark clinical trial in hypertension. After all these decades, hypertension still plagues us globally, so it actually is the number 1 risk factor globally for morbidity and mortality. So if you look at the disability-adjusted life years globally, high blood pressure, tobacco use, and air pollution make up the top 3 risk factors causing burden of disease. In the United States, the prevalence of hypertension varies with age, with race, and with sex. So according to the NHANES database, the prevalence in African Americans is about 40%, and Caucasians is about 27%. The prevalence locally in Jefferson County is about 39%, so we are at the higher end of prevalence of hypertension in the United States. And if you imagine, I just went to the cafeteria and got a cup of tea. There were probably 100 people in the cafeteria eating lunch. A good 40 people would have hypertension. Then the question is, of those people with hypertension, how many are controlled? So if you imagine we have all this access to technology, different antihypertensive medications, even in the best case scenario, the control of patients with hypertension is about 50%. So that's in non-Hispanic white patients. In African Americans and in Hispanics and Asians, the control is even worse. So really, a good half of your patients generally are uncontrolled hypertensives, adding to the potential for complications for cardiovascular disease, cerebrovascular disease, and renal disease. Okay, so we'll use this case to guide us going through the approach and management to patients with hypertension. 56-year-old African-American man presents to your clinic for routine follow-up. He's feeling well. He measured his blood pressure 1 week prior at home, and he noticed a blood pressure of 155/95 with a pulse of 78. He wants to know if this is abnormal, and if so, what should he do? Does your patient with a home blood pressure of 155/95 have hypertension? Possibly. There's some things that we want to look at for diagnosis. The first thing is the methodology. Methodology of collecting blood pressure, it hugely impacts the data that you get. If you take a blood pressure under different situations, you get wildly different numbers. And so it's important to look at this clinically. It's also important to look at this whenever you're reviewing blood pressure clinical trials to see if they collected the information similar to how you collect it in your office. So the patient should be seated in a quiet room, legs should be uncrossed, the back and arms should be supported, and they should be seated for at least 5 minutes. They should have no nicotine for at least 30 minutes. You should remove the clothing off of the cuff location. The middle of the cuff should be at the level of the right atrium, so the midpoint of the sternum The cuff size should be proper. So the adult cuff is about 27 to 34 centimeters arm circumference. And a minimum of 2 readings, intervals of at least 1 minute, should be taken, and then the average of those taken. If there is variability between those of greater than 5 millimeters of mercury, you should check additional readings and then average all of those. In 2017, updated guidelines for consensus statement were released, were developed and released. These guidelines were created by a combination of many different organizations coming together. They included more recent data from the SPRINT trial, as well as some other non-randomized trials and expert opinions. And one of the major differences in this guideline document compared with JNC 7, which was released several years prior, was how they categorize blood pressure. And you can appreciate that what was considered mildly elevated in the past is considered hypertension in this document. So the differences really start with the elevated category. So if you appreciate the diastolic blood pressure of the elevated category is less than 80 in the new document, whereas in JNC 7, they were tolerating a diastolic blood pressure of 80 to 89 for calling it elevated or pre-hypertension, as the prior document called it. Stage 1 has gotten more strict. So stage 1 now is 130 to 139, over 80 to 89. And stage 2 has gotten more strict as well. So now anything greater than 140 is considered stage 2, and greater than 90 for diastolic blood pressure is considered stage 2. Whereas in the JNC 7 document, that was reserved for greater than 160 over 110. This is a very testable chart, and so I would commit to memory how different blood pressures are categorized. So we look at your patient's blood pressure, and the blood pressure is 157 over 92. So according to JNC 7, that would have been considered stage 1 hypertension, but according to this current 2017 document, it would be considered stage 2 hypertension. When you're assessing your patient for hypertension, you want to consider, could white coat hypertension be present? The interesting thing about white coat hypertension is it is not a benign phenomenon. So several studies, including this meta-analysis, show that there is actually a higher cardiovascular risk than normotension for patients who have white coat hypertension. It's fairly common. It occurs in 15 to 30% of subjects who have an elevated office blood pressure but a normal home blood pressure. More frequently in women, older adults, non-smokers, pregnancy, and subjects without evidence of target organ disease. It's not clear why white coat hypertension has a higher morbidity and mortality. One of the hypotheses is that it shows this high blood pressure reactivity to stressful situations, which may lead to higher blood pressure variability. So patients on whom you see blood pressure going up and down, those patients have a higher risk of morbidity and mortality due to cardiovascular disease. Masked hypertension is a different entity. Masked hypertension means that in the home setting, the blood pressure is normal. And, in the home setting, the blood pressure is elevated, and then in the office setting, it is normal. And so to catch those patients, If you have access to either ambulatory blood pressure measurements, that is one option. The document does emphasize that home blood pressure monitoring is an equal recommended methodology for capturing those patients. Another thing you have to consider when looking at patients who have hypertension is, do they have some environmental exposure or some over-the-counter medication or some prescribed medication which can be driving up their blood pressure. So high sodium diets can be verified with a 24-hour urine. It is very common in our region for patients to sometimes eat 8-9 grams of sodium per 24 hours, and that's been correlated with hypertension. Obesity is correlated with hypertension, and there is a meta-analysis which shows that for about every 1 kilogram of weight loss that a patient can undergo, their blood pressure their systolic pressure will decrease by about 1 millimeter of mercury. Obesity is thought to be associated with hypertension in part because of stimulation of a local renin-angiotensin system, which would drive up the pressure through aldosterone. Alcohol use excessively, some herbal supplements such as ephedra, licorice, St. John's wort, recreational drugs such as cocaine and methamphetamines. And then from a prescription medication side of things, oral contraceptives and hormone replacement therapy have been implicated in raising the blood pressure primarily due to the estrogen component, serotonin and norepinephrine reuptake inhibitors, corticosteroids, NSAIDs, COX-2 inhibitors, cyclosporin, tacrolimus, sympathomimetic agents such as methylphenidate, phenylpropanolamine, and pseudoephedrine. So basically this huge long list, it's worthwhile to commit that to memory because as you conduct your medical interview, you'll want to ask patients about these exposures. In the population of patients with hypertension, about 90% have essential hypertension and about 10% have secondary hypertension. So secondary hypertension implies that there is another disease process going on in the body. We treat that other disease process and the blood pressure improves. Generally, the treatment of a cause of secondary hypertension does not completely remove the need for blood pressure medications, but generally it improves the number of medication needed and converts them from uncontrolled to controlled. This is a favorite topic on board exams and something to look into. So they can be categorized in renal disease, endocrine disease, and other. So renal parenchymal disease and renal artery stenosis are the two renal secondary causes. For endocrine, you have primary hyperaldosteronism, Cushing's, congenital adrenal hyperplasia, primary hyperparathyroidism, pheochromocytoma, and thyrotoxicosis. Aortic coarctation and obstructive sleep apnea are also potential causes of secondary hypertension. And you want to consider screening for these if something from this list is available. So, if the patient has resistant hypertension. So resistant hypertension is the clinical situation where a person's blood pressure is uncontrolled in spite of having 3 blood pressure reducing medications optimally dosed, where one of them is a diuretic. So that category of resistant hypertension would justify the expense of looking for secondary hypertension. Abrupt onset of hypertension, a very young patient, so age younger than 30 years. Exacerbation of prior well-controlled hypertension. So many patients will have very well-controlled hypertension for 25 years, and then they'll come into your office and say, for the last 8 months, I've had very difficult to control hypertension. Disproportionate end organ damage for the level of blood pressure control that they've been exposed to. Malignant hypertension, onset of diastolic hypertension at age greater than 65, and excessive hypokalemia, which can imply primary hyperaldosteronism. So when you're taking the history, you want to ask for certain symptoms which might point you towards disease of the heart, brains, kidneys, and eyes. You want to ask about vision changes, headache, syncope, urinary complaints, chest pain, dyspnea. What kind of over-the-counter medications and supplements are they taking? What kind of recreational drugs have they been exposed to? Are they using nasal decongestants regularly? Are they using tobacco or alcohol regularly? What is their level of salt intake? What is their level of caffeine intake? Many patients don't realize that they're drinking 8 to 12 cups of caffeine in a 24-hour period, which can raise the blood pressure. And then assess what their level of activity and exercise is, because that will help you in your recommendations for treatment. Specifically, looking for secondary causes, you want to ask them about muscle weakness. So what disease process am I looking for when I ask about muscle weakness? Just shout it out. So Cushing's can be one. The hypokalemia-mediated primary muscle weakness that results from primary hyperaldosteronism can be another thing that can be revealed by muscle weakness. How about cold or heat intolerance? Which disease? Thyroid disorders. Claudication. What the secondary disease process can be revealed if a patient has claudication. Yes, so claudication would imply peripheral artery disease. So my very first patient who had renal artery stenosis actually had no other systemic symptoms but claudication. So if you see a patient with claudication, it does make you be concerned that they might have vascular stenosis in the renal arteries as well. And cool extremities, of course, goes with that. Sweating and flushing. Pheochromocytoma, very rare. I have seen 3 patients with this, always looking for more, but it's always on your differential. Palpitations is in that same category. Flank pain could imply some type of chronic kidney disease, especially if there's some relation to a cystic disease. And then excessive snoring, what would that imply? So obstructive sleep apnea. So questions like that will help you argue the case towards more secondary causes. Physical exam. You want to appreciate their general body habitus. If they have central obesity, that might be a further cause of hypertension or something that's making it worse. Blood pressure in both arms. Why would you check that? For coarctation. Thyromegaly and assessing for nodules. Your cardiac exam is important for assessing for murmurs. Displaced apex, which could imply left ventricular hypertrophy. Pulmonary edema to assess for risk of heart failure, and arrhythmias. You want to check for flank tenderness, of course, as part of your exam looking for kidney disease. Peripheral edema, neurologic exam, and a good peripheral vascular exam, including carotid, femoral, and abdominal Bruy auscultation, assessing the character of their pulses and assessing if they have any jugular venous distension. A favorite of exams is to demonstrate visually some of the hypertensive fundoscopic abnormalities. So this is a visual going from panel A, which is the upper left-hand corner, which is mild hypertensive retinopathy, all the way down to panel F, which is the most severe hypertensive retinopathy. And so you can see the first abnormalities that develop are copper wiring, which is an orange hue to the vessel when you do fundoscopic exam, and AV nicking. So AV nicking is when an arteriole and a venule cross. The arteriole compresses the venule, and then you see this bulging on the side of the venules from the place where they're crossing. So that's called AV nicking. Next, you may appreciate focal arteriolar narrowing. After that, you may see the development of retinal hemorrhages, which are here and here. And then you may see the development of cotton wool patches, which are actually injury to the nerve fibers. And so they are demonstrating that right here, these white, fluffy-looking plaques. This visual here is demonstrating more of the retinal hemorrhages, as well as some optic disc swelling here. Here's the optic disc. And then finally, in the last, you see this very pale retina with papilledema, demonstrating that higher degree of optic disc swelling, implying increased intracranial pressure. So basic diagnostic tests for anyone the first time they come and see you for hypertension. You should get a basic metabolic panel. That's going to give you your creatinine to look at your GFR, blood glucose to assess for risk for diabetes, bicarbonate. What might bicarbonate help you infer as far as secondary causes? So what if your bicarbonate was high, is what I'm asking. What secondary cause might have a high bicarbonate? Also would have low potassium with that high bicarbonate. So primary hyperaldosteronism, so good to look at that. Calcium might imply some disease of parathyroid or thyroid, rarely. Potassium and sodium, you want to check their complete blood count. What on the complete blood count might help you infer some cause of hypertension?
Anemia of chronic renal disease?
Yeah, exactly. Anemia of chronic renal disease, that would be helpful. A lipid panel is useful in stratifying their cardiovascular risk, so we generally check that. Uric acid, how would collecting uric acid data help you determine what potential medication to use in a hypertensive patient? Yeah, so if they have a high uric acid, maybe prone towards gouty arthritis, you may want to avoid diuretics, which would promote gouty arthritic attacks. Thyroid stimulating hormone, urinalysis. What specifically on the urinalysis will guide you towards different treatment options? Level of proteinuria, absolutely. Okay, checking an electrocardiogram is beneficial for assessing target organ damage. And you're looking for LVH. There are many, many different criteria for LVH that can be used, and this is an example of the Sokolow-Lyon voltage criteria showing LVH by SV1 and RV5. Treatment. So the guidelines have changed as far as when to treat. They have become more aggressive for smaller elevations in blood pressure. So if a patient is in the normal category, that's less than 120 over 80. You always want to promote lifestyle modification, but you don't necessarily have a specific plan that you need to implement. Drug therapy is not indicated, and you can see that patient back again in 12 months for follow-up. If the patient has an elevated blood pressure according to the 2017 guidelines, which would be 120 to 129, and the diastolic is less than 80, you want to advocate lifestyle modifications. At that level of elevation, drug therapy is not indicated, and you want to bring that patient back to your office in 3 to 6 months. If the patient has a blood pressure, which is called stage 1 hypertension, so between 130 and 139 over 80 to 89, you have to determine their atherosclerotic cardiovascular risk over 10 years. And that's an equation created and published by the ACC and AHA, which incorporates age, race, sex, blood pressure, cholesterol, diabetes, treatment of hypertension, and tobacco use. So use this equation. It gives you a percentage of their 10-year risk for cardiovascular disease. If that percentage is less than 10%, you can be a little bit more conservative. You can prescribe lifestyle modifications. You don't start medical therapy, and you see them back in 3 to 6 months. If they have that same level of blood pressure, so this is, again, stage 1 hypertension, 130 to 139 over 80 to 89, but their cardiovascular risk score is greater than 10% over 10 years, you treat them with medical therapy. And then whenever you treat with medical therapy, you want to bring them back in about 1 month to assess the impact of whatever medication you started. So when you start a blood pressure medicine, many times it does take up to 4 weeks to see the full effect. That means if you start a medication and you see them back in 2 weeks and they're not at goal, so you are tempted to up-titrate that medication, they may have further reduction from the original dose, and then they may bottom out their blood pressure. So generally speaking, you don't want to make titration of blood pressure medicines more frequently than every 4 weeks, unless if there's some critical elevation of the blood pressure greater than 160 over 100. So for stage 1 hypertension with a greater than 10% cardiovascular disease risk over 10 years, you are going to prescribe lifestyle modification and drug therapy and see them back in 1 month. If the blood pressure is in the stage 2 category, regardless of their cardiovascular risk, you're going to want to prescribe lifestyle modification and start drug therapy and see them back in 1 month. Now, one of the interesting things published in these guidelines is that if a patient has diabetes or chronic kidney disease, they are automatically put into that high cardiovascular risk category. That means that if they have stage 1 hypertension, 130 to 139 over 80 to 89, you would prescribe drug therapy to get them down to a goal of 130 over 80. So diabetes and CKD is in the high-risk category. The evidence, as they refer in the guidelines, is strongest for patients who have high cardiovascular disease risk, so they firmly say 130 over 80 is your goal for that level of patients. So that's backed up by randomized controlled trials. They suggest it's probably helpful for patients who have lower cardiovascular risk, and that's based on non-randomized trials and expert opinion. But generally, now the new guidelines are saying 130 over 80 That is the goal. And that's a very testable goal, so I'm sure that it will start showing up on different examinations. Okay, so we see our patient. We remember his blood pressure was 157/92. His BMI is 27. He eats frequent fast food, like fast food once a day. He frequently takes NSAIDs for arthritic pain. What do we do next? So we want to prescribe some lifestyle modifications as a first step. Weight loss is one of the most needed lifestyle modifications. You can tell your patients that you can estimate about 1 millimeter of mercury decrease in their blood pressure for every 1 kilogram of weight lost. That's very helpful to give some patients a very tangible number as a goal. The DASH type diet is a high potassium, high fruits and vegetables, a whole grain diet, and incorporating that over 3 to 6 months can improve the blood pressure by 11 points, 11 millimeters of mercury. Reduce dietary sodium down to 1,500 milligrams per day, which is actually very hard to do unless if you avoid fast food. It can reduce your blood pressure by about 5 or 6. Increasing dietary potassium. So not only reducing dietary sodium, but increasing dietary potassium can improve your blood pressure by 4 to 5 points. Aerobic exercise, 90 to 150 minutes per week, can improve your pressure by 5 to 8. And then in patients who are consuming at least 4 alcoholic beverages a day, if you drop that down to less than 2 in men and 1 in women, it can improve their blood pressure by about 4 millimeters of mercury. So these are very tangible numbers that are published in the guidelines that can give you some direction. As you can see, your patient, if they have a blood pressure of 155 or 160, it is less likely that they will be able to incorporate enough of these that they would get their blood pressure to a goal of 130/80 with lifestyle modifications alone. Then we want to look at our initial choice of medication. So something to appreciate. Thiazides, ACE inhibitors or ARBs, calcium channel blockers are all first-line medications in the general hypertensive population. There are different special populations that have different disease processes that have compelling indications to use different medicines. But what category of medicine is missing as a first-line agent? What huge category is not an initial choice of medication? Beta blockers, yes. So beta blockers really for essential hypertension are a fourth-line medication. Specifically note that dual or triple RAS blockade is associated with harm. And so it's very restricted clinical situations where we do prescribe that. And then another principle to incorporate into your practice is if your blood pressure is over 20/10 millimeters of mercury above the blood pressure goal, you can actually start with 2 blood pressure medicines at your first visit. You may want to use medium doses of those 2 medications, and that actually is a very good strategy for avoiding side effects as well. So in this patient, one terrific option would be to prescribe chlorothalidone 12.5 milligrams daily, amlodipine 5 milligrams daily, and then follow them up with an appointment in 1 month. Another important caveat to appreciate: any blood pressure medication that's taken regularly, taken at optimal doses, can probably only reduce blood pressure by about 7 to 10 millimeters of mercury. So if you see a patient with a systolic blood pressure of 170, he or she is likely going to need 4 blood pressure medicines or maybe 3, plus some lifestyle modifications to get to goal. There are special populations which in which different medications are indicated. So chronic kidney disease, if the patient has proteinuria, RAS blockade is appropriately the first-line agent for that patient. If the patient has aortic disease, beta blockade is often the appropriate first-line agent for that patient. In a patient with heart failure, managing their volume overload with diuretics, as well as avoiding medications which cause negative contractility, like the non-dihydropyridine calcium channel blockers, is appropriate. In patients with ischemic heart disease, beta blockers are definitely indicated as initial therapy, and the beta blockers, which are superior in the management because of their improved vascular effects, include carvedilol, metoprolol, nadolol, bisoprolol, propranolol, and timolol. Adding on to that RAS blockade and adding on to that calcium channel blockers if needed. Acute stroke has its own very specific guideline statement for blood pressure management. For that depends on if the patient has an ischemic or hemorrhagic stroke and if thrombolytics are going to be used. So, in the patient with an acute ischemic stroke who's going to receive thrombolytics, they must lower the blood pressure to less than 185 over 110 before those lytics are given. If the patient has an ischemic stroke but is not going to receive thrombolytics, then the guidelines say that if the pressure is above greater than 220 over 120, lower the blood pressure by about 15% over 24 hours. So that would be an expert opinion rather than a randomized controlled trial recommendation. For acute intracranial hemorrhage, systolic blood pressure lowering to 150 to 220 is recommended if the systolic is above 220. There is potential harm in that situation by lowering the systolic to less than 140. And then finally, one of the most beneficial pieces of information we've gotten from several randomized controlled trials is that different races respond better or worse to different classes of blood pressure medications. In African Americans, diuretics and calcium channel blockers are more effective than renin-angiotensin system blockers. And so in those patients, your first-line agents would be the diuretic and the calcium channel blocker, and then adding on to that the RAS blockade, unless if they have proteinuria, then that would be a compelling indication to give that first. Pregnancy is its own unique special population where blood pressure management has different guidelines than in the general population. So in normal pregnancy, what happens to blood pressure? Does it go up or does it go down? It goes down. So generally, blood pressure goes down to a nadir in the second trimester, goes down primarily because of progesterone's impact on the vascular resistance. So if you see a blood pressure going up in pregnancy, it's actually a very abnormal pathophysiologic state. Hypertensive disorders in pregnancy are globally a huge cause of maternal morbidity and mortality. Affects about 5 to 10% of the population of pregnant women, and ranks very highly as far as a cause of maternal death. Even in developed countries, the proportion of maternal deaths due to hypertensive disorders is 15%. Hypertensive disorders in pregnancy are categorized into 4 categories. chronic hypertension, meaning a patient had pre-existing hypertension, then became pregnant, gestational hypertension, which generally is when hypertension onset is after 20 weeks of gestation, preeclampsia or eclampsia, which is when the patient is noted to be hypertensive on 2 occasions after 20 weeks with a previously normal blood pressure, and preeclampsia, which is superimposed on chronic hypertension. So the guidelines are very clear based on to treat if the blood pressure is above 160 over 105 to 110. So any woman with pregnancy and related hypertension should be treated specifically to avoid risk of stroke if the pressure is above 160 or 105 diastolic. The guidelines are very vague and very individualized between the levels of 140 over 90 and 160 over 110. The actual consensus statement by the American College of Obstetricians and Gynecologists recommend that actually no treatment is given. And this is recognizing some of the risks to the placental blood flow if you drop the blood pressure too low. So very different clinical situation, very conservative as far as medical management. If you must give a pregnant woman blood pressure reducing medicine, there really are only 4 to choose from: labetalol, nifedipine, alpha-methyl-dopa, and hydralazine. These are 4 medications which have been used clinically, which have been shown to be safe over decades, and so have been commonly used because of that. ACE inhibitors, angiotensin receptor blockers, mineralocorticoid receptor antagonists are absolutely contraindicated. They are toxic to the fetus. Future directions. So, in 2014, the Simplicity renal denervation trial came out and was halted by the FDA because problems with safety and efficacy, because of efficacy problems primarily. There is a current trial going on for renal denervation called the Spiral Hypertension Off Med trial. So they've released some initial results which are promoting a proof of concept that the device can cause induce an improvement in blood pressure. And so this study is looking at participants with a blood pressure greater than 150 over 90 off medications. And it is showing that after renal denervation, compared with sham control group, the blood pressure is reduced on average for systolic by about 5 millimeters of mercury. And so something that you might very well hear more of over the years. The expected end date of the trial is 2020, and so I'm sure after that they'll be releasing more information. Okay, let's go through a few questions. Question number 1. During pregnancy, a woman's blood pressure normally increases by about 10 millimeters of mercury. Is that true or false? False. It usually decreases by about 10 millimeters of mercury with the nadir in the second trimester. Next question. According to the AHA-ACC 2017 hypertension guidelines, patient with diabetes, no history of cardiac events, normal cholesterol would have a blood pressure goal of 125 over 75, 130 over 80, 135 over 75, 140 over 80. Very good. 130 over 80 is the number to remember from the new guidelines. Okay, so according to the new guidelines, a patient with a blood pressure of 150 over 70 has what level of hypertension? Normal, pre-hypertension, stage 1 or stage 2? Stage 2, so stage 2 is any blood pressure above 140/90. Number 4, which of the following medications are recommended for use if antihypertensive medications are indicated during pregnancy? Lisinopril, labetalol, nifedipine, A and B, B and C. B and C, excellent. Finally, which of the following is not a recommended indication for screening for secondary hypertension? Onset before 30 years, malignant hypertension, excessive hyponatremia, disproportionate end organ damage. C, so actually excessive hypokalemia is the indication for screening. In conclusion, hypertension is associated with a heavy burden of cardiovascular, cerebrovascular, and renal disease. Thiazides, RAS blockers, and calcium channel blockers are appropriate first-line agents for primary uncontrolled hypertension, and the goal blood pressure according to the 2017 guideline document is 130/80. Thank you very much, and I'm happy to take questions. Yes?
Are you considering 130/80 goal in an elderly population?
So that specific question is written in the guideline document for age greater than 65. And they do recommend that for ambulatory patients greater than 65, 130/80 is the goal. For patients who are institutionalized or have some other major comorbidity, they don't give a different blood pressure guideline, and so it would be reasonable to individualize that. Okay, thank you very much.